and that question is based on the findings you had, especially in slide number 11, the issues about assessment, whether it was availability of EMOC, availability or performance. I think that's what I really wanted to know. And I was actually very much curious about the availability of clients, where over 90% people mentioned that availability of clients was an issue. Was there a particular signal function, or maybe was it overall signal functions where they mentioned lack of clients, or was it maybe one particular signal function which really mentioned lack of clients? Thank you very much. I think the next question I'll ask for Helen later, as you just mentioned.
Thank you, Peter. Anyone else with a question?
Good morning, and thank you for the presentation. My name is Abigail from Vihiga County. My question is about the functionality assessment, and specifically on issues of supplies and the issue of magnesium sulfate. And probably I think it could give us more information. Majorly in our facilities, you find that you ask someone, you're referring without giving maybe the pre-medication. The reason is the issue of the fear of the side effects. The fear is not that is what comes out majorly. So the issue is, was the magnesium sulfate available, or there were cases and it was not administered, or what was the main issue? Thank you.
Thank you. Toxicity, I think that will be the question. Anyone else?
Okay, so mine maybe it's a comment, and maybe not for Fiona and whatever to answer, but maybe the people from the ministry can support us in trying to just unpack it. You know, from the findings, when it comes to BMOC, CMOC, we want to say, is it available? Is it being performed? And on the other side, as a country, we keep saying that, you know, our coverage for BMOC is so much, 50%, 30%. So I don't know the connection between what has been presented and maybe what the health facility assessment report said. You know, there was a very nice figure there that, you know, most of our facilities can do BMOC, but we can obviously see that of the 7 signal function, even in those 25 facilities that were assessed, very few are doing it, and yet the facilities were said to be BMOC compliant. So everybody thinks that, you know, all the signal functions, most likely the supplies are there, the staff are competent. Secondly, and I think what is being flagged out is the issue of assisted vaginal births. My question is it that the workers have just refused to do it? What is the national guidance? And what are we really going to do about it? Because to me, it is a subject matter that seems not very exciting, not being implemented for reasons that are beyond me. Okay, thank you.
Good morning, everyone. My name is Patrick Kingori from Jacaranda Health. I was not with you yesterday. My first question is on the EMOC functionality. One thing we observe is that about 0.31 of birds are by AVB, whereas in the review of cases is about 10% should have been AVB appropriate. Although the healthcare workers are reporting that lack of client in a number of about 7 and 8 birds, could there have some in-depth interviews with the healthcare workers that could show that there is a gap in the skill? And as much as we've noted that there is lack of the AVB kits in the health facilities, again, could be the lack of AVB kits worsening the fact that there's no deliveries or the drills in those facilities, or even return demonstration in those facilities, and therefore even healthcare workers who have already been trained are losing their skill over time. My second question will be on the too much too soon part. whereby, again, we see a workload versus CS rate. It is high in facilities that we would expect it to be lower, where healthcare workers, where nurses have a high, in facilities with a high caseload, there are fewer cases of CSs, as against the facilities with lower caseload, where we'd expect maybe this nurse has adequate time to observe these mothers and make appropriate decision. Again, could that be a question of the skills gap, in that we know naturally we tend to pick nurses to go for trainings from the high volume facilities, and maybe somehow we would have left out nurses in the lower volume facilities that also again would need the skill. Do we have some numbers that indicate what is the ratio of EMOC trained versus the non-EMOC trained nurses?
Thank you, everyone.
So I'll try and address the questions in order. So in terms of availability versus performance, and the lack of clients was across the board for all of the signal functions. Were reporting that that lack of clients was the reason for non-performance. We did think about it and wondered whether it might have been almost the easy option in terms of answers, because it was the one that enabled staff, facilities to save face. If there was no clients needing it, then it wasn't their fault. If they admitted that there was lack of staff, that the staff weren't trained, that the staff weren't confident, then there was then a degree of responsibility. But obviously this was routine M&E monitoring, so in that respect we weren't able to sort of dig down into the sort of the deeper understanding of exactly why. But yeah, it was across the board. In terms of magnesium sulfate, sorry, let me put my glasses on. So magnesium sulfate, I think it was because it was a less commonly used drug compared to things like antibiotics and oxytocin, which is obviously used. So antibiotics are used throughout the facility, so those were more commonly available. Oxytocin is used for pretty much every birth. So again, that was commonly available. Magnesium sulfate, as I said, was less commonly used, and therefore was less. That potentially is likely to be the reason why it was less commonly available. But yeah, I mean, in terms of referrals, why it wasn't given before referrals, I don't know. That's not something that we looked at in any real detail. In terms of why they didn't do AVB, I mean, I think if you look at the statistics as well, if you take out the two categories where we were unable to determine because of either lack of information or because of delay, that means that you're left with 30%, just over 30%, who were for whom C-section was appropriate, versus the 10%. So you could argue that actually where we were able to determine the outcome, the appropriateness, a quarter of women could conceivably have had an AVB, which obviously then makes it a much higher proportion. Why they don't do them? I think there are a whole raft of reasons, some of which came out in the interviews. For some, they were very much in favour of AVBs being performed and being available. One doctor who we asked, he said, yes, I think AVB is a good idea. But one of the other questions that we asked was, would you allow your wife, or if it was a female respondent, would you have an AVB? And this one doctor said, if it was my wife now, I wouldn't let it get to that stage, I would do C-section. Which I think was quite telling in terms of, yes, it's okay and it's good in theory, but actually there was almost a security blanket of caesarean section. It gave them more of a sense of control. One of the other unfortunate comments which we had from a medical officer about another medical officer was that because the staff are rotated, one of his colleagues actually was much more interested in the surgical rotation, and therefore when he got sent to obstetrics, he would do C-section because it gave him a chance to practice his surgical skills. I mean, obviously these are sort of outlying comments. You know, they weren't the norm, but it does give you a flavour of some of the sort of thinking that, yes, in theory, AVB is great, but actually there were personal reasons for some people why they didn't want to do it. I think there's also a lack of confidence, and so the lack of basic training in doing AVB, I think, was an issue. A 1-week course where you might get maximum of 2 hours on how to do AVB. If you've never had that basic underpinning training to start with, the 2 hours isn't going to be enough to make you a competent, confident practitioner. And without that support going back into the facility, if your senior colleagues in the facility are not confident and competent, then you're very quickly going to lose any confidence and competence that you have gained if you haven't got that support there. So there is that need for that critical mass within facilities. You know, if your senior says, yeah, well, you might have learned that on the course, but actually I don't like the idea, therefore you're not doing it in my facility, what can they do? So, yeah.
Thank you. Just by way of encouragement, we spent a little while in Garissa a few months ago. We had the KML in Garissa, and after which we did some mentorship in Garissa Hospital, in the regional referral hospital, and we had mentors from the various sub-county hospitals present, and we really focused on AVB training in a sort of intense way with those mentors. Since then, we've had some really encouraging reports from some of those sub-county hospitals that those mentors have gone back and have had the courage to start doing assisted vaginal births. And I mean, it's a really big deal in a woman in Garissa County to be referred in the second stage. The distances are vast, the roads aren't great. It's horrible. I mean, those of you who've had a baby, you'll remember when you're in the second stage of labour, you feel like you're about to die, don't you? It's awful. And to think of being put in a vehicle and bumped along a dirt road for 100 kilometres in that, it's not good. So, I mean, the fact that these mentors have had the courage to start now doing AVBs in those distant sub-county hospitals and to train their mentees to do it too now really encourages me that change can happen, and that we can avoid these second stage caesarean sections often. And, you know, the study that Sobey et al. Published in The Lancet said that the deaths associated with second stage caesarean section, I think it was 12 times as much as the first stage. It was massively more dangerous to have a caesarean in the second stage of labour than in other times. So it really makes a difference to try and avoid them. I think just on top of those things, I think we've proved from our study that the facility assessments saying that there were nobody needing assisted vaginal births just wasn't true. We've shown that there were. It was just people weren't acknowledging that. And again, the assessments sometimes said equipment was missing, but our interviews showed that sometimes the equipment was there, but people didn't have the confidence to use it. In terms of the question about midwifery caseload, I don't think that the midwifery caseload is good anywhere. I mean, you know, compared to international standards, the midwives here have much more work to do, even in the quieter facilities. So I don't think we can say, oh, it's okay in some places and not in others. I don't think it's ever okay, really. And I'm sure those of you who are practicing midwives would bear that out, that you're very, very busy and maybe don't usually, I mean, you'll have quiet days, but on your average day, there probably isn't enough time to devote to your clients as much as you would wish. But yes, you're right, there is an element of anxiety. And I think that can be overcome with better training and better mentorship support. And I just think mentorship is so, and we'll talk about this later on this morning, it's so important to have good mentorship following on from training. Otherwise, you don't reap the benefits to nearly that extent that you should. But also, there's the issue of staff rotation that was addressed yesterday. You can train staff, you can mentor them, they become confident and competent, and then they get rotated to ophthalmology. And what's the point of that? We need experts who are keen practitioners, who love midwifery and love obstetrics, to stay in that field. I think any labour ward benefits from having staff who are, really experienced and really skilled there in the long term. And I think that can vastly improve the quality of midwifery and obstetric care.
Thank you, Helen. Anyone who has a burning question? Probably I want to speak about most facilities Bimong Simong. I think, Dr. you asked about that. Sorry. Yeah, we're almost closing because we need to go to other sessions. Some questions will be asked still in another session. So I want to comment about the facilities. Remember during devolution, did anything change? What happened? Facilities were just elevated and nothing changed. So if you are a facility, you've been elevated, you do not have operating theater, what happens to your clients? You're supposed to be referred, but you are a which facility? You are supposed to be operating clients in your facility. It was elevated, but you do not have that facility. What happens to the clients? And then the politicians who don't want to be referred, these clients are supposed to be operated in their facility. And remember, there is no theater in that facility. Who has failed? We blame who now? As clinicians. Do you blame anybody? We need to offer quality of care. What do we do? Because the facility is supposed to be operating and there's no theater, has an infrastructure. What happens? Hello? You refer, but the facility remains a what? A level 4. But it's not a simple facility. What do we do?
If it is a level 4 facility, it is us to ensure that we advocate for what is expected and let it to the leaders. We need to have a functional theatre. This is what is expected, so that to ensure that this facility operates as level 4. If not, it should go back to level 3.
Thank you. Let it go back to where it belongs, and we do the right thing. We advocate for good services at all levels. And then for me, the summary of all these sessions is about monitoring of our clients using a patograph. Healthcare providers really monitor these clients. Some of them monitor very well, charting on a patograph, but they cannot interpret what they have charted. Isn't it true? They have charted. They saw even here I could have taken action because there was a problem with fetal heart. But I never took action. I continued chatting. I do not know how to interpret this pathogram for action to be taken. So we need to do continuous mentorship when it comes to patograph, because patograph is a tool that is going to inform us on when to intervene when we are having an issue with a client. When it comes to magnesium sulfate, I know the problem is not about magnesium sulfate missing or not missing. It is about toxicity. Healthcare providers fear giving it, and sometimes they do not have an antidote. So what do? A woman continue convulsing, they are not giving, and they are not referring. So we need to mentor nurses on how to do dilution when it comes to magnesium sulfate, and what do you do in case there is toxicity, and how do you even monitor for toxicity during the provision of magnesium sulfate. And then oxytocin. We did a study on oxytocin. We picked many oxytocins in many facilities. What did we find? Tunapeana juice. So this patient continue bleeding, continue pumping this oxytocin up to 80 milligrams, and there is no change. And we are not taking action. We are not referring this woman. So what do? The potency get lost. You get somebody alichukua ice pack, akatoa nje ya cooler box, akasimamisha oxytocin, the whole day iko pale juu. What has happened to the potency? It is not maintained. So what are we giving at the end of the day? Juice. So what is our game changer? What is our game changer? Somebody is talking about carbetocin. You know, carbetocin will come to help us in many ways, especially in the counties where temperatures are haywire, but still we need to maintain the potency of this oxytocin. So any burning question, because we are going for tea and then we come in with a different session?
Thank you, and thank you for the wonderful presentations. Just one comment. I don't know whether you came across unsupervised medical students in the ward and what was their contribution towards patient care. And for the oxytocin, when will the division take into consideration how the immunization program takes care of their cold chain, and also look at sort of having such stringent measures on medicines that need cold chain for effective potency? So to the two panelists and supervised students, what was your take and what was your experience? Then to Karen, cold chain, we can learn from the immunization program.
Thank you, Dr. Laura.
I didn't come across any issues about medical students, but I would say that medical students should not ever be unsupervised. They are not qualified, neither are student midwives. They should not be managing the care of patients without immediate supervision. That's not ethical and it shouldn't happen. I wouldn't want my daughter to have a cesarean section performed by a medical student who wasn't qualified. I don't think any of us would. And, you know, that just should be a no-no, absolutely a no-no. It's not the right thing to do at all, no. And I don't think student midwives should be unsupervised managing labour and giving care either for the same reasons. Oxytocin, yeah, we need fridges for oxytocin. Undoubtedly, there should be a small fridge on every labour ward that is working. That requires a reliable supply of electricity, unless you've got a gas fridge. But we do need oxytocin, you know, will be disabled if it's not kept at the right temperature. So, but I would say as well, there's more, I mean, uterine atony is responsible for 70% of postpartum hemorrhages. There's another 30%. And if you keep giving oxytocin and you've got a different reason, like a lump of retained placenta, you're not going to solve the problem, or some tear high up in the vagina that nobody's spotted. So we mustn't forget, a lot of big studies think, oxytocin given appropriately in the third stage is the solution to PPH. It's the solution to 70% of the PPHs. But if we keep giving it, as Karen said, when the reason is different, the woman will be bound to continue to bleed. We've got the 4 T's, haven't we? It's not just tone. There's the other T's that count for PPH. So we must, explore further in the management of the woman. And this is what we try to teach people. In the advanced course, we've got a specific session on post-cesarean hemorrhage that very much looks at the other causes as well. Thank you.
Thank you very much. We need to appreciate Helen and Fiona, and then we go for tea.